Well, good evening, everybody, and welcome to Ask the ARC. My name is Carly Shirtino-Poulter, and I am the director of the ARC Advocacy Network here at the ARC of Indiana. And more importantly, I'm a parent. I have a 23-year-old son with autism and anxiety, and so I live all of these things with everybody else here. And tonight, I am grateful to have with us Kelli Tungate from Careforth of Indiana today. I know that over the last couple of months, as there have been some massive changes that have been announced for what is currently the aged and disabled waiver and what will be called the health and wellness waiver or the pathways to aging waiver, there's been a lot of questions and there's been a lot of confusion and there's been a lot of fear about some of the changes that are being proposed. And so one of the biggest areas of questions surrounds structured family caregiving. And so we're going to do a little two-part mini-series on structured family caregiving as part of our Ask the ARC series. And so tonight I am very fortunate to have Kelli Tungate joining us. And so just to give everybody a little bit of an idea of who Kelli is. Kelli is Kelli has a Master of Social Work and has been with Careforth, which was formerly called Caregiver Homes of Indiana, for nearly 10 years in a variety of different capacities. She was the first state director of operations for Careforth of Indiana when structured family caregiving was introduced by FSSA through both the CIH waiver and the aged and disabled waiver back in 2013. In her current capacity, she serves as the Senior Vice President of Strategic Partner Relations. And prior to joining Careforth, Kelli spent 18 years working with SACOA Aging and In-Home Services, which is the local area agency on aging here in the Indianapolis and Central Indiana area, and also worked in a variety of different capacities. She started off as a care manager with SACOA, and with her last position there, she was actually the Chief Operating Officer. But Kelli spent her entire career working with older adults and individuals of any age with a disability. And she's a caregiver herself, providing direct care and support for multiple family members with chronic health conditions. And I think we all know that, when you live it, you understand it in a very different way. Kelli is a native Hoosier and lives here in Indianapolis, and she's passionate about supporting family caregivers and in helping family care keep care at home. Now, I do also want to share a couple of little housekeeping announcements, which is that first of all, we are recording tonight's presentation, and so I want you to know that so that you're a little careful about the information you're sharing. I just want to make sure that we're maintaining everybody's privacy. I will also say that you are going to be able to ask questions in both the Q&A and in the chat, but we're going to hold off on those until the end of the presentation to make sure that we get through all of the material. Unfortunately, we're not able to allow people to ask questions by unmuting, but go ahead and put those questions in the Q&A or in the chat, and we will get to as many questions as we possibly can. And so at this point, I'd like to turn it over to Kelli, and thank you so much for joining us today.
Yes, Carly, thank you so much. Are you able to hear me okay? Everything good?
Sure can.
Fantastic. I'm going to have you hold on this slide for me if you don't mind.
Okay.
If you don't mind, I just want to make a couple of opening remarks. Carly, thank you so much for the introduction. It's truly my pleasure to be here tonight with families from across the state to provide an introduction to structured family caregiving. I've got a tremendous amount of respect for the work that Carly and Kim and Indy and others do at the ARC on behalf of thousands of vulnerable adults and children across the state. So I really appreciate the opportunity to continue to strengthen our working relationship. And I've appreciated the opportunity to get to know each of them better in the last several weeks. So according to the Family and Social Services Administration, there are approximately 8,000 families across the state of Indiana who are receiving SFC services today. And that was a number that was just shared during the legislature this spring. Before we get started this evening, there are a couple of comments I want to make about this webinar and the materials that we're about to review. First, I really want to acknowledge that there's been a significant amount of turnover inside FSSA, and specifically the Division of Aging, which I'm not calling out positively or negatively, it's just kind of a fact over the last 12 to 18 months. I think with that turnover, there's been overall a loss of true institutional knowledge of what structured family caregiving is. And to that point that Carly made earlier, I think with the changes announced by the Family and Social Services Administration around legally responsible individuals, that lack of institutional knowledge and people who have known the service for some time has created a lot of misinformation to the point that Carly was making. There was a lot of the misinformation happening when the legislatures were in session with family members across the state. And so, you know, this evening, I want to really speak to you from structured family caregiving as defined under the aged and disabled waiver today. You know, as you guys know, and as Carly mentioned, families that are currently served under the A&D waiver will be transitioning to the health and wellness waiver as of 7/1, and of course, pending CMS approval. It's important to acknowledge and to call out in this webinar that there are differences between the service definitions for structured family caregiving under the aged and disabled waiver today and under the community integration and habilitation waiver today. Those service descriptions do not match. And that, again, is neither right, wrong, or indifferent. They are serving different populations of individuals. But I just want to call that out to this group that they do not match today. Careforth is currently engaging with Family and Social Services Administration and DDARS as they work to provide guidance and clarify the role of family caregivers under SFC, in particular with regard to medication oversight and allowable activities as a structured family caregiver. So this is to say in flight, if you will, with the current administration. I know it is their desire to create consistency in the delivery of the service under what is now today the aged and disabled waiver, what will in the future be the health and wellness waiver and the community integration and habilitation waiver. So this process will be fluid as we continue to build our relationship with DDARS and broaden their understanding of a service that has historically been underutilized on the CIH waiver. Some of the content that I'm going to share with you this evening to that point is subject to change as FSSA and DDARS work through the guidance in SFC in advance of the launch of the health and wellness waiver. So I want to call that out. I'll call that out here. I know that there's a couple of slides where I will continue to call that out and want to make sure that that's clear. So my goal really this evening is to provide each of you with an overview of the service as it is defined in the aged and disabled waiver, regulations, and provider manual today. I have included one slide in this deck that speaks to Careforth's professional support framework for SFC, which is intended solely to outline the type and level of support caregivers should directionally expect to receive from SFC providers after July 1st. Other than that, all details that I share this evening are straight from the Aged and Disabled Waiver Manual and SFC service definition as it signs today, or as it is today. I also just want to point out, well, while there may be some variation in how the service delivery standards are administered by SFC providers, this overview should provide you with specific details about what the service you should expect to receive from any SFC provider in the state. So Carly, if you'll go to the next slide, I'm not going to spend a lot of time here. I just want to provide some context. And I want to make sure, I have lost your slide.
That's because I stopped sharing the screen. So let me get back to that piece.
Okay, got it. All right. Give her a second here. So the next slide is really just to provide some context for who Careforth is, and I think why the ARC asked us to present this evening. Careforth is actually the innovator of structured family caregiving and the service. We introduced the service to the state of Massachusetts over 20 years ago, and since then have launched across multiple states, serving individuals over the age of 60 and those under the age of 60 with disabilities. In 2013, we worked collaboratively with FSSA, including the Division of Aging and the Division of Disability and Rehabilitative Services, to introduce the service. Today, we're serving over 4,300 families across the state. In totality, we're providing services to over 10,000 Medicaid members and 15,000 family caregivers in our SFC program across 10 states. SFC is really a unique service, and I hope that as you learn more about the service, you understand its uniqueness. The goal of SFC is really to wrap professional and financial support around informal caregivers, allowing them to provide care with confidence at home. I also just want to point out that in the last couple of years, we worked very closely with DDARS to introduce another service under the Aged and Disabled waiver, which will be available under the Health and Wellness waiver, known as caregiver coaching. So if you'll go to the next slide, Carly, I just want to provide a high-level overview, again, tied directly to the service regulations and service description as to what structured family caregiving is. It's a service in which the waiver participant lives with a principal caregiver who provides daily care and support to the waiver recipient based on their daily care needs, and of course, as assessed by the waiver case manager. The waiver recipient may live in their own home and have the caregiver reside with them, or the waiver recipient may reside in the home of their caregiver. And I want to call out too here, when we talk about family caregiver, we really mean have a broad definition of family caregiver. So it may be the individual's chosen family caregiver. It could be a longtime family friend. It could be a neighbor that they trust. So it's a very broad definition of family caregiver. But they may or may not be related, but they must live together in a home. The goal of the service is really to ensure that the participant receives the necessary personal care while fostering and emphasizing the participant's independence in a home environment that will meet the participant's needs as those needs change over time. We'll talk about this in just a moment, but it is the responsibility of the agency, the SFC agency, to credential the home, to credential the caregiver, and to credential the care recipient. Caregivers receive professional coaching and a modest financial support to provide care. Ongoing coaching ensures the caregiver understands and is prepared to manage care and behaviors as the member's chronic health conditions progress and as needs change. Only agencies are allowed to provide structured family caregiving, meaning an individual could not provide to become a provider of structured family caregiving, could not apply to become a provider of structured family caregiving. Providers are responsible for ensuring the homes are accessible and appropriate to meet the participant's needs, and that caregivers meet the qualifications established by state rules. There are 3 levels of care for structured family caregiving, and we'll talk about this a little bit more in a couple of slides. It is the waiver case manager's responsibility for assessing and determining the participant's level of care. The provider agency must capture daily notes that are completed by the caregiver in an electronic format. That is straight from regulations. And they must use this information collected to monitor the participant's health and to support the caregiver's needs. The agency provider must make notes available to the waiver case managers and the state upon request. And finally, in terms of an overview, home visits are completed by a registered nurse and/or a caregiver coach as determined by the person-centered plan of care. Carly, if you'll go to the next slide. So again, I want to call out that you see a couple of asterisks here on this slide. These are activities allowed today under SFC, under the Aged and Disabled waiver. Those may be subject to change in the pathways, the health and wellness, and the TBI waivers effective 7/1/24. That is something as we kicked off this meeting, I want to continue to reiterate that DDARS and FSSA are revisiting these allowable activities and intend to issue guidance for both the Aged and Disabled waiver today, but also as important for the health and wellness waiver after 7/1. So those allowable activities are supporting the waiver participant with activities of daily living and independent activities of daily living, including those noted on this slide, providing transportation to appointments and community activities, accompanying the waiver participant to medical appointments, and medication oversight to the extent permitted by state law. And I know that that is a very important subject for many of you on the call. So again, I want to just call out that the FSA and DDARS is working on that. Today, under the Aged and Disabled waiver, Careforth has interpreted this rule to say that caregivers are permitted to remind waiver participants when it's time to take their medications. They may assist in ensuring that prescriptions are filled correctly and in med reconciliation activities with their care team, but they may not administer medications. We realize that under the CIH waiver, caregivers are able to complete what's known as medication administration certification or training and to administer those meds. However, it's not allowable under the A&D waiver today. So as I stated, FSA and DDARS will be working to provide further guidance and clarity regarding the role of family caregivers, medication oversight, and allowable activities of those caregivers in SFC. If you'll go to the next slide, Carly, I want to talk a little bit about the service standards of providers. Agency providers must demonstrate 3 years of delivering services to elders and adults with disabilities, caregivers in Indiana, or as a Medicaid participating provider in another state, or have a national accreditation. They must develop, implement, and provide ongoing management and support of a person-centered service plan that addresses the participant's level of service needs. They must conduct, at a minimum, 2 quarterly home visits on the participant's assessed needs, based on the participant's assessed needs and caregiver coaching needs, but the actual frequency of visits may be based on the participant's assessed needs. Providers of SFC can make as many visits as needed on a quarterly basis to support those families or as requested by those families. Caregivers will receive a minimum of 8 hours of in-person annual training that reflects the participant and the caregiver's assessed needs. Training may be delivered during quarterly home visits or in another manner that is flexible and meaningful to the caregiver. Agency providers must work with participants and caregivers to establish backup plans for emergencies and other times when the principal caregiver is unable to provide care. Paid unskilled respite services must be provided by a qualified qualified caregiver familiar with the participant's needs during those times when the primary caregiver is absent from the home or otherwise cannot provide necessary level of care. Respite for the principal caregiver for a maximum of 15 calendar days per year. And I want to pause on this, if you don't mind, Carly. I want to pause on this just to kind of talk this through. There were some questions that were posed in advance of this session. Careforth has been working with the Division of Aging for several years, trying to bring greater clarity to SFC providers regarding their responsibility to provide unskilled respite. We've, again, neither here, there, indifferent, we've not yet received that clarity. And as a result of that, providers across the state are likely delivering unskilled respite in a variety of ways. The only thing that I can speak to is how Careforth delivers unskilled respite at this point. And our teams work actively with the primary caregiver to identify other informal caregivers who can be credentialed to provide services in absence of that primary caregiver and to be paid for delivering that care. Today, families are also able to access adult health services, adult day health services, as a means of respite for that primary caregiver as well. If you'll go to the next slide, again, I wanted to provide our professional support framework simply as an example in general of the type of support you should be receiving from your SFC provider based on SFC regulations. This is simply one example, and today we know that there are nearly, it's shocking to say this, nearly 200 providers of SFC across the state that have been approved by the Division of Aging. While we believe that all providers should be delivering the same level of support to families, we know that that level of support is being delivered differently. So there's absolutely no question that a caregiver's stipend rate matters to family, as we'll talk about, but my hope in sharing this slide is that it's an example for each of you to understand the component of the service that includes ongoing professional clinical support in your role as a caregiver. So much as we've talked about earlier in terms of service standards, there should be a personalized caregiver coaching plan. There should be a personalized care team that's there to support a broad range of caregiver needs and to employ caregiver coaches who have diverse skills and professional backgrounds. A care team for us is comprised of an RN care manager and a care manager. The caregiver and the consumer are play a very active role in, of course, that care team as well. But that care team is really responsible for care plan development that's personalized based on building caregiver education, support, and skills for that specific caregiver, in delivering person-centered coaching on the caregiver and the consumer's needs, identifying changes in the caregiver and member's status. And we do that in a variety of ways, whether that is the electronic daily check-in, which our care teams are monitoring on a daily basis, through our home visits, through ongoing interactions, telephonic or otherwise, with our care teams, so that we can support and mitigate risk of emergency room visits, falls, any of those types of things for families. And then finally, you should expect not only an initial assessment or an annual assessment, but an ongoing assessment of your needs as a caregiver and the support needs of the family member that you're caring for. You'll go to the next slide. There are, as we mentioned previously, 3 levels of service. And so I want to address levels of service and caregiver stipend payments. These levels of service have been broadly publicized. They're available in a number of materials published by the state and materials that have even been posted to the ARC website. So those are the rates that a provider is able to bill upon validating care delivered for levels 1, 2, and 3 on a per day basis. It is the waiver case manager's responsibility for determining level of care in their assessment using a state mandated assessment tool. Current regulations do not require a specific percentage of the billable rate to be paid to caregivers. Caregiver stipends may vary by provider, as may the frequency of payments as well. So that is going to vary by providers. The question has come up about whether income received through structured family caregiving is taxable income. So stipend payments are made to caregivers providing SFC under a Medicaid home and community-based service waiver are considered difficulty of care payments by the IRS and are non-taxable. Having said that, while those stipend payments are excluded for tax purposes, caregivers must report that income anytime they themselves are applying for any type of benefits. For example, housing and/or SNAP benefits. So we're going to talk, there were a couple of questions submitted in advance of this conversation around caregiver stipend payments, so we'll be coming back to that and levels of care. If you want to go to the last, not the last, but the next slide, Carly, in speaking with Carly and other representatives of the ARC, we understood that some of you may have questions about the process for becoming a provider of SFC services. So I wanted to share this slide with you to explain a process that the Indiana Division of Aging has put in place to bring more providers of SFC service into the aged and disabled waiver. So in February of 2024, FSSA published information and included a webinar that is available on the FSSA website on how to add structured family caregiving as a service and a new prioritized provider enrollment path to providing attendant care services, CIH structured family caregiving, and CIH residential habilitation. So FSSA stated that the purpose of the expedited reviews that they've put in place is to ensure that no individual loses service with the removal of legally responsible individuals as being able to provide care for their loved one under attendant care, structured family caregiving on CIH, and residential habilitation programs under CH. This will ensure continuity of care through waiver transition as of July 2024. That's the stated reason for the state putting this prioritized or expedited path in place for SFC providers or future SFC providers. Eligible providers must meet current waiver, current waiver approved HCBS providers enrolled to provide attendant care on the A&D waiver and or SFC on the CIH waiver. A lot of acronyms, sorry about that. The deadline for submitting a request for providers was 3/28, and so that deadline has closed. I'm not sure what the state's stance is at this point on individual provider organizations that didn't meet that deadline, if they're continuing to accept, but the published deadline was March 28th. There are certain minimum requirements that the provider organization must meet by June 1st to be eligible for expedited enrollment. So they must have identified backup plans for SFC principal caregivers. They must have caregiver coaching secured and identified and a registered nurse in place, and that is to be evidenced by job descriptions and an updated org chart. Those are the preliminary requirements that must be met by June 1st. Of course, all of the service requirements, the agency requirements that I covered in previous slides must also be met by July 1st. So they'll be issuing conditional certification between March 28th and June 1st. The expedited enrollment process will result in providers being able to begin delivering services on 7/1. And of course, upon approval of CMS of the health and wellness waiver. We do not expect provider qualifications to change after the implementation of either the pathways or the health and wellness waivers. So I'm hopeful that that provides some direction for any of you who are currently working with an attendant care agency who has indicated that they are on an expedited path to becoming an approved service provider for SFC. The last slide here before we jump into questions from the chat and those previously submitted is we felt that it was really important to provide this group with just some preliminary questions to think about as you are exploring what provider, if you should transition to SFC, which provider will best meet your needs and provide the highest quality of services to you and to the member that you're caring for. So these are simply some sample questions to start a conversation. I won't be reading through all of those, but I do hope that these are helpful. It's important for you to really vet the organization with which you will be working. As I mentioned previously, prior to the February timeline, we believe there to be roughly 90 providers of structured family caregiving in the state. Just about a month ago, we heard from the Division of Aging that an initial 100 providers had received conditional approval to provide SFC, and there were still a number of providers who are waiting that conditional approval. So the volume of SFC providers is going to grow exponentially, and we want to make sure that you have the tools in your toolkit to make the right selection regarding the provider that you believe will best support you and your needs. Carly, I know that there probably, I think I've seen some things jumping in here in terms of questions. So I thought I might just thank you for the list of questions that you sent to me prior to this meeting. If you're okay, I will read through the 7, 8, or 9 that we received and provide some responses, and then we can move to the chat questions. That sounds good?
Great, Kelly. That sounds great.
Okay. Okay. So the first question or comment is that FSSA presented SFC rates to families and legislatures as having 65 to 70% of the reimbursement rate to families. What incentives do agencies have to meet that rate? And in parentheses, it says, note that agencies who currently provide the service and those who have already announced their new service rates are coming in below this range, that's 65 to 70%. What I would say to that is this is one of the areas we consider to be a bucket that requires further clarification from FSSA. Regulations as they stand today, both under CIH and the A&D waiver, do not require a specific percentage of the provider's billable rate to be paid directly to a credentialed caregiver. We know that a bill passed this legislature that requires FSSA no later than December 31st of this year to present recommendations for setting a required minimum percentage of the reimbursement rate for both attendant care and structured family caregiving. And we also know that no later than November 30th, FSSA is to provide information to the Budget Committee concerning the transition from attendant care of a legally responsible individual to structured family caregiving and the impact to those families. So we are in conversation now with FSSA officials to better understand what providers are doing now and what they should be expected to be doing in the future. The second question is, as the service definition is currently written, SFC is incompatible with respite nursing. How can families who opt for SFC and who currently do have nurses providing respite retain those individuals in a service other than respite nursing? Again, in parentheses, state plan PA nursing hours are not approved for all families due to the stringent PA requirements. The currently defined respite component of SFC is incompatible with nursing regarding both the hours and level of care. I do not disagree with this statement at all. We as an organization do not. Again, this is a subject, I shouldn't say again, this is a subject that we provided public comment to FSSA on as part of the waiver process. There were a couple of recommendations that we made. The first which was to in the waiver service definition to reinstate or restore the qualifier unskilled in the description of respite services. And the most recent, at least the most recent published waiver service definition, it had removed the word unskilled and left respite open. So we recommended the restoration of unskilled. SFC providers have never been obligated to ensure the availability of skilled respite services. We are confident that FSSA is exploring this issue, and we will be continuing our advocacy in support of allowing members with skilled respite supports through the waiver to be able to continue to access those services. It is something we will continue to advocate for. And yes, we realize that not every family may qualify for state plan or PA hours, but historically we have been able to coordinate skilled respite services through PA through prior authorization when the caregiver is in school, working, there are dignity of care needs that are identified, or other instances where the caregiver has made commitments outside of the home. I know that that is not necessarily the answer many of you want to hear, but one of the components of having that structured clinical care team support is to help and support families tackle challenges just like this. So we will continue to advocate. In the meantime, families who would happen to come into our service, our care teams work actively with them to solve for challenges like this. The next question, when should tier determination processes be solidified? And by tier, I interpreted that to mean level of care determinations. It is a new age demographic for the aged and disabled, meaning minors, and a new service altogether for TBI participants. Has the tier determination process for those two been solidified? When will it begin? Where can families and care managers find this? So again, waiver care managers are responsible for conducting the level of care assessments, and they should be conducting those assessments right now. I want to make sure that that's really clear. Today is April 9th. We know that families will have to make very difficult decisions between now and June 30th. If your care manager has not instigated a conversation with you about structured family caregiving or about identifying another individual to provide attendant care services, I urge you to be reaching out to them as quickly as possible. The level of care assessment produces a score which tells the waiver case manager which level of care an individual is eligible to receive. I am very much aware that the state is and has been conducting trainings for waiver care managers on the administration of the Inter-I, and I believe the level of care assessment tool for the pediatric population. I think that they have been actively working to provide additional training and support for their care managers on the administration of those tools with specifically the pediatric population. And while the state might be considering changes in the future to the tools used to assess children under the 18, there are no changes to those tools as they exist today that I'm aware of. And to answer the question about TBI, yes, SFC will be a new service under the TBI. And again, the existing tools will be used to determine level of care needs and eligibility. What steps should families take if they disagree with the level of care determination? All waiver service recipients and their families have the right to appeal the level of care determination or any waiver determination directly with the AAA. That appeal may, or independent case management agency, I should say, that appeal may be ultimately elevated to a state level or an administrative law judge as appropriate. Care managers, waiver case managers should be notifying you of your right to appeal initially and throughout the qualification process. Question, the provider agency must conduct a minimum of 2 quarterly home visits. What does this visit consist of? Can they be done virtually? The waiver regulations don't specifically stipulate what the visit should consist of. Having said that, we did review the service provider obligations as part of this presentation. So providers at a minimum should be ensuring that they're meeting those obligations during home visits with families. For our care teams, we review goals outlined in the plan of care by the waiver recipient and the caregiver, barriers to achieving those goals, changes in conditions or medication, what's happening well in the home, what's not, assessing the waiver recipient and the caregiver relationship, and identifying opportunities for the care teams to better support families. Those are just some examples of what you should expect to receive in those home visits. With regard to the question of virtually, those visits must be completed in person. So there are some instances when a visit may be done virtually, but the 2 visits are required and mandated on the face-to-face visits are mandated on a quarterly basis. The next question, great questions, by the way. Thank you guys so much for submitting these in advance. I hope that some of these are addressing questions that might be coming into the chat. Principal caregivers receive a minimum of 8 hours of in-person annual training that reflects the participants and principal caregivers' assessed needs. Training may be delivered during quarterly home visits or in another manner flexible and meaningful for the caregiver. Is there anything that dictates what this training must consist of? Can this training be provided virtually? So any educational training provided SFC for caregivers should first and foremost be person-centered and focused on having a meaningful impact for the waiver recipient and caregiver needs, as we stated previously. Caregivers are actually required to sign off on those 8 specific hours of required training. So we do those, or that to me would say that they would need to be required, completed in face-to-face. But providers may be able also to provide some components of additional training outside of those face-to-face visits virtually. How does SFC, next question, how does SFC work with shared custody arrangements? Is there any reason a provider couldn't hire 2 caregivers and split the payments? The SFC provider is responsible for credentialing all identified caregivers who intend to be reimbursed for care. Careforth issues the caregiver stipend to the individual who completes the electronic documentation of care. So what the primary caregiver does with that stipend payment then is up to them. But we are only permitted to bill for 1 caregiver per day delivering services and issue 1 caregiver payment to 1 individual. And the final question that was submitted prior to this evening's webinar is, how will SFC work in regards to days that count and don't count? For example, if your child is hospitalized, do you get the stipend for the day? Is this change based on how long they are or aren't in the hospital? This would say, when the public health emergency was implemented, the Division of Aging did implement flexibility that permitted SFC providers to bill and thus pay a family caregiver while the care recipient was hospitalized, if we met certain standards of documentation to show that care was still being provided to that individual by the caregiver. With the end of the public health emergency in mid-November, this flexibility was discontinued. So today there is no mechanism in place for providers to bill and thus pay caregivers during a hospitalization. Services must be interrupted during that time, meaning that caregiver payments will not be made. This is a topic that is very near and dear to us, and one that we submitted public comment on and continue to try and engage FSSA in terms of reinstating this benefit to family caregivers. We know that care continues while your loved one is in the hospital, and we understand the fiscal burden that causes family members when they're unable to be paid for the care that they continue to provide. So Carly, that is the last of the questions that were submitted in advance. Again, absolutely great questions. I hope that I was able to adequately address those for the group.
Well, thank you so much, Kelly. It really was incredibly helpful. And we have gotten a few more questions that have come in. So I want to get to those. Um, and some of these you've actually touched on in the answers that you've given on some other questions. I give my daughter, one is about medication. I give my daughter her medication in a banana because she doesn't know how to take it with a liquid. Would this be a problem?
As the standards are written today under the aged and disabled waiver, that would be considered medication administration and it would not be permitted. I can't help but to continue to reiterate in conversations with FSSA that there are different requirements if an individual is being provided care under CIH versus aged and disabled, and the state intends to provide additional guidance and create greater clarity on permissible activities by paid caregivers under SFC services today and in the future.
We've got a question on, well, a couple of questions on caregiver coaching. Regarding caregiver coaching, what are the professional qualifications? What kind of input does the caregiver have as an individual service plan is developed? Many families of medically complex individuals who are performing many medical tasks deemed trainable by Indiana Medicaid have expressed concerns about spending precious time on an appointment when they don't find actual value in the coaching service. So,
well, the first question I'd ask is, have they had quality coaching service? I mean, have they actually been receiving the level of coaching support, again, we would expect them to receive through Structured Family Caregiving? And so that would kind of be my first question. I prefaced any of the comments that I made around person-centered. And so our care teams, our nurse, and our what you call social services designee, that could be somebody with a behavioral health background, it could be someone with a social background, are really focused on creating a plan of care that meets the needs of that caregiver and ultimately the individual that they're taking care of. So it's a very interactive process that our team works with that caregiver to ensure that we are meeting their needs in the type and quality of support that we're providing.
Another question, what will the daily note-taking process be like? How will that be done? And then I'm adding a question there. Does that vary by provider agency?
It does vary by provider agency. I'll give you my organization, then I'll say some more to that. Our organization uses a HIPAA secure platform. So our caregivers are able to conduct asynchronous communication with their care team to complete what we call a daily note or daily check-in. They tell us what type of care is being provided in the home, if there have been changes in condition, has there been any type of incident that has occurred, and our care teams are responsible for reviewing those notes on a daily basis. I don't know, Carly, if when this transition happens to health and wellness waiver, if family caregivers today who are providing attendant care and completing perhaps an electronic visit verification note, I don't know if that EVV is something that would be acceptable to the state in terms of documenting. And I don't personally have insights into what type of information is included in an EVV to know whether that would qualify. But yes, I think providers, not every provider has a HIPAA secure platform to which they're using to communicate with families. So my guess is providers are doing things very differently across the board.
Yeah. Somebody's asked, who would be assessing the homes, such as ones that may need to be wheelchair accessible or who have adaptive equipment within the home for the person receiving services?
So initially, obviously, that's the waiver case manager. Secondarily, it's our care team. And that's really, when we say we are responsible, or provider organizations are responsible for credentialing, it's ensuring the safety of that consumer inside the home and identifying opportunities to enhance the safety or to enhance the mobility and access to the home that that individual may have. So that's how we consider from a credentialing or assessment standpoint, that would be the nurse care manager and the social work type person who's supporting the caregiver through that assessment process.
Can a caregiver provide SFC to two participants in the same home?
They can. I believe the maximum is 3 participants. I believe it is 3 participants. The state will not permit you to provide SFC for more than 3. In those instances, the caregiver would be responsible for completing an electronic daily note for each care recipient and would be paid individually for each care recipient.
So we've talked about under SFC that SFC allows up to 15 days of non-skilled respite per year. What if somebody needs skilled respite, skilled nursing respite? How does that work when you're using structured family caregiving?
Yeah, that was one of the points I hit on in the questions and answers. There's no easy answer to this. As I mentioned, SFC has never been permitted to be provided in conjunction with skilled respite nursing under the waiver. As I mentioned, our families, our care teams, our nurses, our social workers work very actively with that caregiver to identify other informal supports who might be able to provide that skilled care. We, request and solicit PA, prior authorization hours, whenever possible, to support that individual. But it's an area of advocacy for us, and I'm sure for the ARC of Indiana going forward with FSSA.
But you did also mention that it may be possible, and it's all very, all very specific to the individual. It may be possible for somebody to be using structured family caregiving services and still get Medicaid PA nursing at the same time.
Absolutely, correct.
Okay. So are the SFC considered 1099 contractors?
They are not considered 1099 contractors. They are independent contractors, but under the difficulty of care stipulation by IRS, we're not required to issue 1099s, nor have we ever issued 1099s. There may be instances where, I should say, where, as I mentioned, a caregiver is applying for benefits and they may request a document that shows the amount of stipend payments made to them in a year or over a period of time, which we would produce. But individual providers, caregivers are considered independent providers or independent contractors who sign an agreement with the SFC provider to provide care.
Have you received any guidance from FSSA regarding structured family caregiving for that pediatric population? And any indication from them when that guidance might be available?
We have not received any additional guidance, nothing that is not out there publicly in terms of, I mentioned, the training that FSSA is pursuing with waiver case managers. There has been mention of whether the state, I believe the state is investigating what other pediatric population assessment tools might exist and whether they would be appropriate to adopt in the state of Indiana. But my personal opinion is, this is just me speaking, it's going to take some time for them to get there and to implement any change around the assessment tool that they might use for the pediatric population.
Okay. I see someone else on here is saying that their case manager told them that they cannot conduct structured family caregiving level of care assessments because there's not a pediatric level of care tool available yet.
That's not fact.
Okay. And this is me taking a side note here. That's one of the things that we're hearing for families as they're calling us is that I think part of this is there are so many changes going on right now, and it's difficult even for case managers to get up to date and accurate information themselves. And so there's a lot of confusion in all of this. And so, we have families who are contacting us saying their case manager is saying, certain things that may not be accurate. And that's not because, they're trying to be nefarious or anything. It's simply that I think there's that much confusion right now, even within the agencies, even with the people who should be able to answer these questions and who should know the information, they just don't know it yet. And I think part of that is also that this is still an evolving situation. Um, so
Carly,
how, oh, go ahead.
just for a quick second, just to that point, we as an organization have begun to put monthly webinars on the books. It's voluntary for AAAs to participate, but because of the exact point that you were making around misinformation around SFC, misinformation around the waiting list that was just implemented, right? Like, we're trying to do our part to help keep them educated, but it has been a challenge, and perhaps not to fault of their own. It's just, as we kind of spoke about, the lack of institutional knowledge, the fact that things are changing on a day-to-day basis. So, it's not to point fingers at them, but,
Right.
we are certainly trying to do our part in educating.
Well, and I will also say, words matter here. And so sometimes we can have people who think they're saying the same things and they're not. And so sometimes the specific word usage actually, kind of changes some of the information, some of the answers to some of the questions that may be coming out too. Um,
Yeah.
how should SFC handle medication administration that's needed for clients? And what about medications through tube feeding? Because we've got a lot of families who have loved ones who are tube fed.
Yeah, absolutely. Again, not permissible today to manage. Our care teams are really incredibly crafty. We help that caregiver identify other informal supports to provide the medication administration. I can't tell you, probably we have hundreds, if not more than 1,000 families who receive prepackaged medications that you can get delivered to the home. And so the caregiver can then point to, it's time to take this medication. I know that may not always work, or will not always work, with the pediatric population where there are severe developmental or physical disabilities, but those are some of the types of solutions that care teams should be working with families to try to solve for, until the state provides further guidance.
Sure. What are the requirements for the person providing respite care in terms of ongoing training?
They must meet the same credentialing requirements as the primary caregiver who's been credentialed. So it is the same requirements in terms of ongoing, how we get them qualified and what the expectations are for ongoing education.
Okay. Um, and I think this is one of those questions where it's kind of getting to the heart of getting used to a new concept here. With structured family caregiving, how many hours of care are required per day?
There is not a set required number of hours. In a structured family caregiving setting environment, it's an environment where the caregiver has taken responsibility for ensuring the 24-hour day, 7-day a week care needs are being met for the individual that they're caring for. So this is not like an attendant care where I'm required to provide 5 hours of care based on a plan of care. It is, what are the care needs of the individual? And those care needs may be from, 6 a.m. to 9 to help them get ready for school. While they're at school, then they pick back up after school is out. It really is individualized and based on the needs of that individual.
Looks like we've gotten some more questions that have come in.
Great questions, Carly. These are great questions.
Um, let's see. Sorry, I'm going through to make sure that I'm not going back over some of the ones we've already asked. Are there situations that EVV can be waived? for example, with protected address participants.
I'm not sure I understand the protected address
So, and I think
part
that
of that.
I think this is a very specialized question. So sometimes there are some individuals who have been the targets of various crime or domestic violence or things along those lines, and where their addresses themselves are actually protected. And so I think
Okay.
that's something that we'll need to follow up with the state. And I will also say some of the questions that we have gotten in, um, I haven't necessarily asked because I think those are questions that are better that are more applicable either to state personnel or on Thursday night we're having Evan Reinhardt, who's the executive director of the Indiana Association on Hospice and Home Care, come in. And so
Okay.
I think some of those questions that I haven't asked tonight that have been submitted may be better answered by Evan on Thursday night. And so if we haven't
Sure.
asked your question yet, know that it may just be that I think it's probably a more appropriate question for someone else to answer. And so I will also be giving him those questions in advance so that he can try to prepare some of those questions. Um, but we've gotten a couple more. What is the process like for a parent to change providers, and how long does that take?
It should be a smooth transition from moving to one service to the next. You would obviously begin the process with your waiver case manager, notifying that you intend to change provider organizations. Much of the credentialing work that SFC, I'm assuming it's SFC to SFC provider. That's my assumption here. But much of the credentialing work should be translatable and transferred to the new SFC provider. So it's a matter of the waiver case manager making a change and setting an effective date of the change of that waiver service and the provider being able to accommodate that
And
date.
I'm thinking they may be thinking more switching from an attendant care provider to a structured family
Okay,
caregiving provider.
okay, okay. I would say get on it, Carly. I would really say get on it. There's a lot. Waiver case managers across the state have a lot on their plate right now. A lot of things that they're trying to support families, and not only this transition, but the transition to managed care in general. So I think it's really critical that these waiver case managers are working with families today. We know that after July 1st, attendant care services will be no longer permitted for legally responsible individuals. And so, between now and I would say no later than mid-May, those waiver case managers should have completed the assessment, the level of care of assessment, have supported the families in identifying the most appropriate provider, and submitted the waiver, the new service plan to the state for authorization prior to 7/1. I would say we've seen slowdowns in service authorizations being approved, and obviously now the wait list. The sooner the better for them to get those service plans in so that the state is able to get them authorized for change in provider on 7/1.
Yeah. And then we have one final question. Is the provider required to provide a non-skilled respite caregiver, or does the family have pre-planned respite caregivers?
Again, this is one that we continue to seek clarity from the state on. And so for us, that individual has to be someone who has been credentialed just as the primary caregiver and is able to step in, complete the daily check-in, and to be paid for those services. I can't speak, Carly, to how other SFC providers are administering SFC. I simply can't.
So First of all, Kelly, thank you so much for this. I know that there has been so much confusion and the concept of structured family caregiving is still so new, not only to so many families, but even to a lot of professionals in this world. This is, structured family caregiving is not something that has necessarily been it's not a service that you immediately think of, and so it's brand new to a lot of people. So thank you for taking the time and really explaining what all of this is. I know that people probably still have a lot of questions, and frankly, if you are anything like me, you're going to think of more questions later on. I do want to remind you that we are having a second webinar on Thursday night at the same time at 6 o'clock to with Evan Reinhardt, who's the executive director of the Indiana Association on Home and Hospice and Home Care. I screw up that acronym every time. Sorry, guys. But he's going to be on to talk about all of this some more. And so I want you to come back and listen to him, listen to the things he has to say. He's kind of looking at this from a slightly different perspective, but also come back with your questions, especially as you think of these going forward. I will also say, in my opinion, it is incredibly important that if you are looking into this service, that you actually call up providers, interview them. Remember, you know, they work for you just as much as you may work for an SFC provider. You want to find out, what those providers are like. I love the fact that in your in your list of questions that you asked, some of the things you were encouraging people to ask were things like, how long have you been doing this? How long have you been providing structured family caregiving? And how long have you been providing it in Indiana? Because we have a lot of brand new providers who are coming in from out of state who may not be as familiar with Indiana. And so what are they doing to know their specific communities that they're serving? Do they know your community? And how important is that to you? A lot of different things to consider with all of that. I know that we at the ARC are working on an information sheet to help give families some ideas of different questions to ask. We hope to have that out relatively soon. In part, we were waiting for these webinars to be able to pull some of the questions that people had from this to help us draft that tool for families. But Kelly, thank you so much for joining us this evening. And everyone, thank you so much for joining us. I hope this information was helpful. I know that one of the frustrating things is that there still seem to be a lot of open questions. And again, I don't think that that's anybody's fault. I think that everyone is trying to figure out, how do we actually make this work? And so thank you for joining us this evening. We hope that you are able to join us on Thursday night as well. And have a wonderful evening, everybody. I also want to say, if you have more questions, if you want to talk about this, with one of our family advocates, give us a call here at the ARC of Indiana. Our number is 317-977-2375. You are welcome to talk with any of our family advocates, to ask whatever questions you have, try to get a little more clarification, and get whatever support you can. So thank you all so much and have a wonderful evening. Good night.